Dear colleagues, I'm Dr. Pierce Lin from Universal Eye Center, Taiwan. This talk is about pain and haze control after PRK. Pain management and haze control are two major issues after all surface laser ablation, like PRK, EK, and even more modern form of trans-PRK or Streamlight. About pain management, we need to reduce the causes of postoperative pain, including inflammation caused by loss of corneal epithelium and temperature rise during laser ablation. For topical anesthetic eye drops, we use propalacaine or tetracaine if no allergic history found. Sedative or anti-anxiety drugs may be applied to calm down the nervous patients. Pain management assessment can be recorded according to phases scale 0 to 5 degree to determine increase or decrease dosage of pain-relieving drugs. Good communication is very important to relieve anxiety and tension of patients. We should emphasize painless sensation during the surgery itself and guide patients to have reasonable expectation for postoperative pain. During operation, we can apply cold BSS of 4 Celsius degrees to irrigate the cornea for more than 3 minutes. It will reduce the rise of temperature during laser ablation. We use NSAID eye drops for preoperative period, QID for 3 days and 3 times in half an hour before operation. For postoperative period, QID to Q2H for 2 to 4 days, or you may soak the bandage contact lens in NSAID eye drops in advance to reduce pain. It can reduce haze and regression too. Steroids and antibiotics like fluoroquinolone eye drops are mandatory to reduce inflammatory reactions and prevent infection. Comfort eye drops, such as diluted tetracaine, should be used cautiously because delayed epithelium healing might be a problem. Oral medication has no obvious effect, but NSAID, steroid, or other oral drugs are preferred by some doctors. After the operation, immediately cold compresses or ice packs over the closed eyelids is reported to reduce pain severity. Better fitting overnight bandage contact lenses is highly recommended, especially high DK values, and tighter bandage contact lens to improve healing and reduce pain too. Follow-up is mandatory to comfort patients and understand the current situations. The causes of haze is related hyperplasia of myofibroblast, which related to deep ablation, delayed epithelial healing, less hormone or less tears in the menopause period of patient, high IOP, exposure to UV light, infected area, sensitive constitution like acne or rosacea, hyperopia or high astigmatism. Grading of haze is classified as 5 grades, from trace to 4 grade, which is severe corneal haze, preventing reflection and completely obscuring iris detail. There are 2 types of haze. Type 1 tend to appear in 1 to 3 months after surgery, and then disappear after 3 months to 1 year. Type 2, also called late onset corneal haze, appears after 3 months. It can persist for more than 1 to 3 years. Type 2 haze will induce regression of reflection, as well as delay haze recovery. Prevention of haze. You should choose patients with low to middle powers of myopes and smaller apical zone in this ablation. Smoother surface type of ablation, such as TPRK, is better than EK or traditional PRK. Avoid UV exposure with sunglasses during the first 6 months or even longer after operation. Screen out sensitive constitution such as autoimmunity, scar, acne, allergy, or family history of glaucoma. Maintain the moisture of dry eye service is very important because dry eye may increase haze severity. Avoid infection, of course, very important. The application of topical mitomycin C to prevent haze is highly recommended by most experts. 0.02% mitomycin C is the standard concentration used. For low to moderate myopia under 6 diopter, we apply mitomycin C immediately after laser ablation for 20 seconds to 1 minute. For high myopes, hyperopia, or high astigmatism patients, we apply longer from 1 minute to 2 minutes, then BID or QID for 1 to 4 weeks period. Treatment of severe haze by steroid therapy may be effective. The target is grade 3 or grade 4 haze, and patients whose vision is lower than expected best corrected vision by more than 3 lines. The dosage is as following. Triple the treatment amount, 3 groups of 1 drop every 5 minutes for each group. The frequency is TID or QID per day. The later appearance of haze, the longer the period treatment time needed. It also depends on individual sensitivity too. Besides pain management and haze control, other post-operative regimes should be managed carefully, such as infection, halo, central island, ectasia, descentration, corneal erosion, and persistent refractive errors. So, in conclusion, pain management and haze control after PRK can be managed properly to enhance the satisfaction of patients. I wish all your patients happy with PRK. Thank you for your attention.